Good morning, everybody. You're all very, very welcome to this morning's event. My name is Eddie Cassidy, and I'm the chairperson of ILFA. Today we hold our second virtual patient information day of 2023, and we have a morning planned with a fantastic lineup of guest speakers. We are grateful to all our speakers for their time and their expertise, and I hope you will enjoy all of their presentations. As always, with virtual technology, we hope everything will run smoothly, and we're extremely grateful to have Justin Dawson helping us to arrange the technology once again. The order of speakers this morning is Professor Anto O'Regan, Olive McCafferty, Patricia Davis. We will then take a small break and will rejoin with Sean O'Shea, Lindsay Brown, Leah Harrington, and Frank O'Connor. Questions can be submitted via the chat function on the bottom of the screen and will be raised after each presentation. Our first speaker this morning is Professor Anto O'Regan. Professor O'Regan is a consultant respiratory physician with a specialist interest in pulmonary fibrosis, who works at the University Hospital Galway. Professor O'Regan is a former chair of the Interstitial Lung Disease Group at the Irish Thoracic Society and is an extremely good friend to ILFA. Professor O'Regan's presentation is entitled Progressive Lung Disease. So with that, I would hand over to Prof. O'Regan, please.
Sure. So listen, thanks very, very much for the invite and for the introduction as well, Eddie. I do want to start by just thanking ILFA really for all the amazing work they do, and I want to thank everybody for joining on a Saturday morning. So I'm sure this is something that is hard to integrate into our day, but we're delighted that you joined us today. So I'm going to just start off. I'm going to try and share the screen, and I suppose as I say this, it is a little bit tricky sometimes to distill things over a virtual platform, but and I try and be as precise as I can. But that's why we have a question function, because when you have specific questions, then we can try and answer them in our panel and after the talks. So I'll kick off, and what I'm talking really about is lung fibrosis, and I think everybody knows what lung fibrosis the term, but what my aim today is to talk a little bit about the lungs, a little bit about what fibrosis might mean in the lungs, how it affects the lungs, and we'll touch on treatment at the end of the talk. And so we're just on this slide here. And so what I try and maybe think a little bit about when we're talking about lung scarring or the lungs is there's three major compartments, I think, in the lungs. And the first here, if you look at the left of the screen, is a blue sort of tubular structure. They're the big tubes that we breathe through, and what they are the bronchi or the bronchioles, and or the windpipe. And what their purpose is to bring air in and out of the lungs. Okay, so if we just then click, Justin, and as the air brings in and out, it inflates another part of the lung, and that part of the lung is like millions of little balloons, and they're very, very easy to inflate. They're not difficult to inflate. And as you see, as it inflated there, it then presses against a red structure, which is the blood vessel. And the purpose of the lungs is to put the oxygen from that really delicate structure into the bloodstream. And we call that big round bubbly thing in the middle the interstitium of the lung. So we have the airway that we breathe through to get air into the lung, and then we have this very delicate structure, which is called the interstitium of the lung. And that hence the word interstitial diseases, I'll say in a second. So if we just click again there, Justin, for a second, and one more time. So the major, like in our clinics, most people who come in to see us have problems in the tubes. So you've heard of asthma and you've heard of smoking-related lung diseases like emphysema. That problem is in the tube that feeds into those little balloons. However, if we click again, Justin, that balloon structure is where we have this thing called interstitial lung disease. And interstitial lung disease is where that particular part of the lung becomes less functional, as I'll show you on the next slide. And if it becomes damaged, then you get symptoms of cough and shortness of breath. So this illustrates, again, the same picture, but the little brown box now looks like it's not quite as compliant, not as easy to inflate. And if you click just in there, it just doesn't expand like it normally should do when you take a breath into it. And surrounded by that is some crisscrossy brown sort of this box. And what that tells you is that the lung now in this interstitium is stiff, and it's not getting in contact with that red blood vessel as much. So it's not able to do the function of it. It can't get that oxygen as efficiently into the bloodstream. I'll show you that on a slide a little bit later on. And really the critical thing we're saying is if that part of the lung, the interstitium, gets stiff, there's a fundamental question that we ask. Is it inflammation or is it scar tissue? And I'll show you, if we click onto the next slide, some of the terminology that we use. Scarring is called fibrosis, and I'll be repeating this on a few slides. But when we talk about scar tissue, when we talk about fibrosis, what we're talking about is scarring in the lung. And the first question really, is it scarring or is it inflammation, or is it a mixture of both of these? The second question that we have to ask, if it is fibrosis or scarring, is it getting worse over time? And that's a term we call progressive, or is it, when things progress, they are getting a little bit more prominent over time. And if we click again, Justin, and then is there a particular cause? Is there a driver for these changes that we need to identify either in the environment or on the medicines or in the body that might be important to think about? So if we click again there, Justin, please. So just to reiterate this, so fibrosis means scarring. Just to reiterate, when I say scarring, if you look at the top of the screen there, scarring on the skin will never go away. So we know once there's scarring there, we can't make it go away. So it's a really important decision. Whereas inflammation we can make go away, scar tissue cannot be removed. So what we're always, once it's scarring, we're thinking about how can we keep it where it is and stop it getting worse over time. And what happens in the lung, if we think about it, is constantly being exposed to stuff in the viruses and little particles in the air, so it's always getting a little bit damaged, and it has to repair itself continuously. And in this situation with scarring in the lung that we're talking about today, that repair process doesn't turn off as effectively. So it does its repairing. If we look at the arm there, that scar tissue has repaired itself, but it stops. And in the lung, sometimes this keeps on going, and that's what we're taking a look at. So if we just go to the next slide, there's a terminology that I wanted to just kind of, we've often heard of idiopathic pulmonary fibrosis. So as again, fibrosis is scarring, pulmonary means the lung, and idiopathic means that we don't know the cause of it. And if you look at the bottom of this screen, we're now using a slightly different term. We're using the term progressive pulmonary fibrosis. Progressive means it's getting worse, pulmonary means the lung, and fibrosis means scar tissue. And actually, idiopathic pulmonary fibrosis is a subset of progressive pulmonary fibrosis. And this is important, as I'll show you in a second, because what we're really doing when we meet somebody with a lung disease like this is we're trying to work out if it's getting worse over time and at what pace it's getting worse over time. So these are the critical questions. So in my own mind, I'm moving away from the term idiopathic pulmonary fibrosis that we don't know the cause of, and thinking really, if there's fibrosis, is it getting worse over time? So if we click again, there are important considerations in this disease. It's slightly more common in men than it is in women. If we click again, Justin, about 80%, and it's going down a little bit, but about 80% of people get a diagnosis over the age of 70. And although the cause is unknown, what we know is as our lungs get, as they age, their repair processes become less efficient. So they don't repair injury in the same way as they would have done when we were younger. And some of that is in our genes for sure. And what we know is on the genes that there are specific genetic tags on our genes that allow us to repair things without too much difficulty. But as we get older, like a lot of things, those repair mechanisms don't work as well. And some people are a little bit more susceptible to that than others. And that's probably one of the key reasons why we see this in people over the age of 70. Well, we can't really identify a clear cause. We know there are important considerations. So if we click again, Justin, we know smoking is associated with this condition. Okay, so about 60% of people who get lung fibrosis smoke. We know there are things in the environment. So asbestos is probably the where people used to work many years ago with asbestos is one of the clear environmental triggers for lung fibrosis. But things like people keeping birds at home. Some people are allergic to birds, and they can get this. In the old days, farmers' lung used to be important, but if you live in a rural community, you realize we don't use hay anymore. We use more like silage, so we don't see farmers' lungs so much anymore. Sometimes it's in the medicines we take. And I always just double check that people aren't taking specific antibiotics for recurrent urinary tract infections, because they can cause lung scarring. So we need to see a full list of medicines to just make a proper assessment. And we click again. And sometimes it's in the rheumatological, so rheumatoid arthritis and related illnesses. So we do a very careful assessment for any of these causes, because if we identify something in that list, then that is something that we will want to address separately from just looking at the fibrosis. So we click on again. Thanks, Wilson. So the symptoms: shortness of breath and cough, and they can be very insidious. They can just creep up on us. A lot of times we don't feel that breathing, but when we think back a year ago or 2 years ago, we know we could do more. And that's really one of the symptoms we want to highlight with people. If you're feeling breathless, let's get this checked out. And when we check it out, the GP and the specialists in lung fibrosis will look at your oxygen level, but also listen to your lungs. And what we're listening for at the bottom of the lungs are these little crackly noises. And I'll show you on the next few slides why we can hear those. This is a chest X-ray, and you can see over 4 years, the one on the right, I won't go through exactly what the X-ray is, but essentially what we're looking at is the diaphragms at the bottom of those little rounded things, and the black circles, black shadows are the lungs. And I think you can see they look smaller over 4 years. The amount of blackness in the lung is less prominent. And that is this idea that the lung is stiff and it can't expand. So if we click again, if we look, then everyone who has this condition will get a thing called a CT scan. And a CT scan, and it's difficult on a virtual platform to explain, but a CT scan is like a cheese slice. It's like we can see a slice of the lung, and it's like cutting down from the breastbone at the front to the vertebrae at the back. And the black rounded structures again are the lungs. And if you again, it's hard because we can't put our fingers on the screen, but those black circles are very homogeneous, and there's little squiggly lines in those black circles, and those little squiggly lines are blood vessels. If we move over to where Justin has the pointer now, that is a lung that has scarring in it. So you can see there's a very big difference between the lungs, and there's lots of little round black circles, and that's the scar tissue. And that lung has become very stiff. It's hard to inflate, and that is the fundamental problem with this. And if we click again, what this is, we use this analogy of the old bellows of the lungs. The lungs open and close, and it just becomes, if you think of an old bellows, it's hard to inflate and deflate, and that's because of the scar tissue. So the lungs get smaller and they get stiffer, and that's the problem that we see with this condition. And what I try and illustrate this with in the next slide is, if you just think of 2 types of gloves. Here's a glove you might see in the hospital. It's very easy to inflate that glove. It's a very simple process, like a balloon. And if you think about a rubber glove you might use at home in the kitchen, that's very hard to blow up. And that's really what's happening in the lungs. That is fundamentally why people become breathless with this condition, because it's more work. If you think of trying to blow up that rubber glove, it's harder to do that. So it's harder to inflate it. So it's more work to do that. And that's fundamentally where we're doing. And that what we call that compliance. And compliance basically means how easy it is to inflate a balloon. And if it becomes incompliant, it's harder to inflate. Okay, so we'll go on then, Justin. Thanks. So the other thing I want to just illustrate before we talk a little bit about monitoring is what the fundamental issue that I showed you was that when the lungs inflate, their job is to put oxygen into the bloodstream. And this is nothing more than just a sort of a process of a machine moving along, and we're trying to put on this kind of line of things, we're trying to put oxygen onto the actual conveyor belt, as you see here. So that works very efficiently in our bodies. But if we click again twice now, Justin, into the next one, what happens is, as I showed you earlier, the balloon doesn't hit the blood vessel as closely, so there's more distance. So if you're further back, and this man is trying to put all of these things or check these things on the conveyor belt, if he's back further, it's harder to do that. It's harder to get the oxygen onto the conveyor belt. And then one of the critical things is, if we click again, is as we walk, because our heart pumps faster, the blood flow moves faster, the conveyor belt is moving faster, we've more distance to lean onto that, so the oxygen doesn't get onto the conveyor belt as easily. So when people with lung fibrosis walk, their oxygen level will drop, but yet when they're not walking, they often have a really, really normal oxygen. So it's that pace of the movement that's really important here. So clicking on, when we're thinking then about it, we have two things. We've clicked twice now, Justin, thanks. The size of the lungs, and the second thing, and just keep clicking there until one more, thanks. The size of the lungs and how the oxygen gets into the bloodstream. So these are the things we measure when patients with lung scarring come to our clinic. So what's the size of the lungs? And we call that the vital capacity. So you'll see the term FVC, or forced vital capacity, and that's that test. And I had put in a slide on it, but it's not in this one. It's basically, you'll remember that telephone box if you've been in a lung function lab. We're measuring the size of the lungs. So again, if they're shrinking, then these values will get smaller over time. So we're looking at that. And then we're also looking at how that oxygen gets onto the conveyor belt, and that's called gas transfer. And that's the test called the DLCO, which you'll see when you're getting the test. Or we will take a walk and look at the oxygen in the bloodstream when you're walking. So remember, the reason we walk the test is because we'll see what happens to the oxygen as the conveyor belt moves faster when you're walking from the heart. So those are the things we check. So we click again. So really what we're looking at is the first assessment is, what are your symptoms? How long have you had them? So we try and date, are those symptoms something that we can tell if it's a year or two, maybe more years ago? We obviously have to think a little bit about, is there any drivers, as I said previously? Then you look at these two aspects of lung function testing, the size of the lungs, which is the FVC, and the oxygen movement, which is the DLCO. And then we do that walk test. And we look really on walking, we ask three questions actually. I put up oxygen, how far you can walk, what is your oxygen, and then how breathless do you feel when you're walking? And these are all important when we're making our initial assessment and then continuous assessments. So that's just an illustration that if we want our total, our vital capacity, the VC, to be over 80%, if it's at 63%, we know it's a little bit lower. And then that value that we have is 2.89 liters, which means it's a nearly it's a 2 liter bottle of 1.5 2-liter bottles of Coke is really what you're looking at. That's the size of the lungs, and then we can measure that over time, and the same with the DLCO and the walk test there. So we won't dwell on that too much. Now, the key question I said really when we're now honing in on this is, you will see a lot of people who have CT scans because we do them more frequently. Some people will have some scarring on those CT scans, but not all of the people who have scarring on the CT scans have scarring that will get worse over time. So the critical question for us is, what happens over time? And I've tried to illustrate here that the green line here that you can see, so worsening disease on one axis and time on the other, is what happens if you have lung fibrosis that's getting worse over time. It declines, so the actual lung function decreases over time, and that's what we're measuring. There are a small group of people where that can happen rapidly, and there are a small group of people where it never changes over time. And then if you look at the blue bars, there are some people where it seems to be very stable, then suddenly it can just get worse out of the blue. That's usually with a chest infection. So it's very important to have some understanding of what we're looking at over time and why we're looking at it. But we always give a signal. If you have a chest infection and you're feeling more short of breath, get checked out into the GP or give us a call and we'll have a look at things, because that's where we want to maybe escalate some treatment at that point. Now, if we go to the next slide, is when we're measuring things when you come to clinic, and we will see people with lung fibrosis usually about every 6 months, and we're looking at how symptoms are. So we like to track the symptoms, and we look at our lung function, and what we're looking at in that size of the lungs, is there been a 10% drop? Or in the oxygen movement, is there a 15% drop? So that's really what we're looking at. And if it exceeds those two values, then we are a little worried that things might have gotten worse. But actually, my approach then is to always repeat that again in 12 weeks, because there is variation. So I want to just be clear that when we're doing the tests, they're hard tests to do. If you've ever done these tests, they're difficult. So we don't always perform quite as well each day we do it, but that doesn't mean necessarily that it's gotten worse. So we do 2 tests to make sure that there is clarity on that. And we do the walk test I don't do a lot of CT scans. I don't find them as helpful as the walk tests and the blowing tests, but occasionally we do them. Okay, so we'll just move on now to finish up on treatment. So when I started this, there was really no evidence behind treatment at all. And we used to give anti-inflammatory medicines. And it gets back to that context when we looked at this. When we think about this, is if we think there's inflammation, we will give anti-inflammatories, but not if we think it's scar tissue. And the reason for that is when we looked at this in a large trial, which is called a randomized controlled trial, you'll see at the bottom, that means it's a very good trial. It didn't seem to help. So we were giving medicines that didn't help. Now, there was a vogue for giving antioxidants, and I see some people are still on these medicines, but if you click again there, Justin, but we didn't really see a huge benefit. So it's not a medicine I give. And that's because if we click again twice, because about 10 years ago now, we had good quality studies that showed that 2 drugs made a difference. And those drugs were called pirfenidone, which you might know as Esbriet, and nintedanib, which you will probably know as Ofev. And in large trials and subsequent follow-up over the 10 years, these medicines do make a difference. And if you click again, Justin, what they do is, and it's very important, they don't stop the condition, but they slow it down significantly. So what you can see there on the brown line versus the green line is the lungs are doing better over time, but they're still dropping a little bit more than they should, but you're extending that time out that the lungs are staying healthy. And this gets back to, if we click again, when we're thinking about treatment, what I really want to focus on before we look at the different aspects of this is our job as doctors is to try and help you keep your lungs as good as possible for as long as possible. If we know there's a condition that's getting worse over time, we can't turn it off completely, but there's a lot of things we can do to keep it from making you feel unwell. Now, we know that transplantation is an option, but there might be 25 transplants in a year in Ireland. So what our job is to make sure we look at everything we can do to keep the lungs as strong as possible. And if we click, if we exercise and rehabilitation you'll be hearing about that, is critical. And I'll show my last slide is just in terms of what that's about. But rehab is about keeping the machine of our bodies as fit as possible. It's not just about the lungs, it's about the whole machine. Then we look at those, is there scarring in the lungs? And if there is, then we look at these medications. And I won't say that one is better. They seem to be pretty much the same in terms of what they do to help us or help you, but they have different side effects. So that's sometimes something that we have to think about when we're choosing medicines. If we click again, the antioxidant I won't talk about now. Oxygen is important. Now, again, my approach, and again, I'm going to just note this, that when someone with this condition walks, their oxygen level will often drop. That is not a reason to necessarily be on oxygen, but there are times where we'll sometimes have to give oxygen to help your exercise. But a lot of people, when we're dealing with this condition, we don't have to use oxygen for the most part. It maybe when it's really progressed, we sometimes will have to give oxygen, but we try and push to look at exercise rather than oxygen. If we click again, transplant I mentioned, it's something we always have to be vigilant. We'll make referrals for transplant, but because transplantation is a huge undertaking, we're always trying to preserve lung function. It gets back to the same thing I said before. And at the last click, it's very important to think a little bit about symptoms and the control of symptoms. We always have to think into the future, all of us, and we should have our own wishes known on how we want symptoms to be managed and looked after into the future. We need to let our friends and relatives know that, and sometimes we need to make sure that there's somebody that can help us with those decisions, and that's where we talk about durable power of attorney and making decision making and advanced decision making capacity for people, because symptom control is absolutely critical. When we give medicines, we want people to feel better. The anti-scarring medicines, the antifibrotic medicines do have side effects and they help us, but what we're always trying to work is how do we minimize symptoms, because quality of life is so important in this situation. So we'll just click again, and this is the last slide just on pulmonary rehabilitation. And it really is just, again, we'll talk about this so much. It's when we feel sick, if I have a cold or I'm feeling sick, I reduce my exercise, and it's much easier not to exercise because you don't feel like it. But in lung disease, the body has to be as fit as possible. And that's probably one of our key messages. We have lots and lots of other things we can do, the antifibrotic medicines, oxygen. Sometimes we use anti-inflammatories when someone gets a bit sick. But at the end of the day, it's that machine, keeping that fit and getting out and trying to do a little bit of walking really makes a difference to this condition. So I'm going to finish there. I think there's one other slide. Just I would say this was the west of Ireland today, but it's not. But it is the west of Ireland. This is Salt Hill, where I can pretty much see from here, and it's a wonderful place. But it's an outdoor slide, and the reason I put it there is that's the prom, and we see a lot of people with lung disease walking the prom, and it's getting out to trying somewhere you like to go for a walk and try and enjoy those lovely seaside views when we're living in Galway. So thanks for that. I hope that it gives it's some resonance and you have some idea about that, and I can take questions whenever Eddie feels is appropriate. So thank you.
There's a couple of questions that's come in there, Anthony, and thanks for the presentation. Are there any developments in changing the use of oral antifibrotics to inhaled antifibrotics to reduce the side effects?
Yeah, it's a very good question. I mean, so just to say, first of all, the answer to that is no, but there's a lot of work being done looking at how we deliver medicines. And indeed, as important as that question in how we deliver them is, are there new medicines coming through the truth? There are pipeline medicines being developed, but there are no medicines in the last 9 years that are new to the market for this condition. The idea of an inhaled medicine is very attractive because the condition, as the question indicates, does sit close to the air tubes. In fact, maybe the air tubes are the nidus that drives a lot of the scarring, but they're probably very, very deep in the airways. And while it is a very attractive idea that we can put something into the airways and have less side effects, it's not something that's available presently. And just to go back to that original picture I showed, the blue tube is really easy to get medicine in. So a lot of people that we see, walking around with lung disease like asthma, they will be taking an inhaler, but you could see what I was trying to show is it's much deeper in the lung. It's in the very, very small tubes that we breathe through rather than in those big tubes. So there are logistical issues of getting medicines in that deep into the lung. So the answer is no, but I mean, I think these are all areas that we're exploring and we're hoping to get more information on.
Now, we do have some anonymous questions coming in, Anthony, and you have access to the Q&A box. Yeah. So we will answer them throughout the webinar. Just one quick one there as well. Some doctors say that the oxygen level should not be below 94 even when exercising, and if it does, oxygen should be given. Is this correct?
So again, you'll have different doctors will have different views, and different physiotherapists and nurse specialists will have different views. My view, the evidence, so the first thing to say is the key value for sitting at rest for oxygen is 88%. So if it's less than 88%, we would generally make a decision that oxygen should be worn for about 16 hours in a day. So quite a long time, but then there's a good 8 hours you don't need oxygen. The evidence just shows no benefit in using oxygen if it's above 88%, except for symptom improvement. So in my view, and that's been studied, in my view, you use oxygen if it makes you feel you can walk and do more. So it's for symptom benefit, but for no other benefit. So I don't think we should be thinking about 90% or 80 or 88 or 86% even when you walk. It's about whether you feel better on oxygen and you can do more. Now, because we had an epidemic of COVID, it did get into people's kind of mindset that 94 and then 92% were triggers for treatment. That's a different issue because in COVID, that was acute pneumonia. And that was the signal we were using to give a certain type of treatment, which was steroids for COVID. So maybe it crept in at that point. But no, the answer is that actually my answer is try to think about symptoms and not fixate on oxygen, because you'll end up doing less rather than more if you're looking at the oxygen. So if you feel like doing it, get out there and walk and don't worry about the oxygen so much. I think it's how you feel is more important.
There's a lot of questions coming in. We're conscious of time, and a couple of people saying, can they ask some questions to you, Anthony, afterwards? And I'm sure you're happy to have them as well. Some attendees can't stay for the full 2 hours. So I'm conscious of time. Thank you, Anthony. I'll pass on to Eddie for the next presentation.
Okay. Thank you very much, Anto, for that very informative presentation. Moving on now, our second speaker today is Olive McCafferty, Senior Physiotherapist at the National Heart and Lung Transplant Unit at the Mater Misericordiae University. Olive recently ran the Dublin Half Marathon to raise funds for ILFA in support of her patients. So we're very grateful to her. Definitely very grateful. A great achievement. Olive's presentation is entitled Exercise and Wellbeing. So I will hand over now to Olive.
Hi there, everyone. Firstly, I'd like to thank ILFA for inviting me today. I think it's a fantastic opportunity for me to speak in front of so many people. And secondly, I'd like to thank ILFA for all the work they do. I think it's a fantastic charity and you just do such great work. And yeah, I'd really like to commend you on all the work you do over the years. So I'm just going to try and share my slides. I titled this Exercise and Wellbeing because I think exercise has such a big part to play in having good well-being and a good lifestyle. So I think they come in hand, and I hope by the end of this, all of you will agree. I just want to quickly outline what we're going to talk about today. I just want to talk about why exercise is so important, how much exercise do we recommend, what exercise should you be participating in, and using oxygen while exercising. I could talk forever about the benefits of exercise, but even just some simple little ones. Exercise is shown to improve your ability just to do day-to-day tasks. So hopefully it'll make life a little bit easier because you're stronger and fitter, but also has a really nice benefits for your mental health as well. And I know oftentimes living with a long-term condition, sometimes our mental health can take a little bit of a hit as well. So there's not just physical benefits, but there's also mental health benefits. As your physical fitness improves, your body becomes more efficient at using oxygen in the bloodstream and transports to the working muscles. So I often think as the lungs is the center, although exercise might not change what's happening in the lungs, but your muscles on the outside in your arms and your legs and your torso become more efficient at using what you give it. So the fitter we are, the better our body is at using what you're already giving it. Not only does exercise improve many, many things, but it also reduces your risk of other conditions, which obviously having lung disease, having another comorbidity or other diseases will make life only harder. So exercise has been shown to reduce your risk of other illnesses such as heart disease, stroke, diabetes, some forms of cancer, including lung cancer.
Sorry, Olive, can I get you to move your mic just a bit closer to your face there? Yeah, perfect.
Is that a little bit better?
That's much better. Thank you.
Perfect. I didn't want to be shouting. And it also has shown to reduce anxiety, depression, improves memory, and reduces your risk of dementia, including Alzheimer's. So that is just a small few of the benefits and the reduction of risk that exercise can help with. I think it's important as well to establish the difference between physical activity and exercise. I'd often have patients tell me, I'm on my feet a lot during the day, or I'm pottering around the house a lot during the day. So we would class this activity or those types of activities as physical activity. This is where you're maybe doing household chores, your activities around the house, perhaps maybe at a little bit of a lower intensity. There's many benefits that come with being physically active, but once we go into the bracket of exercising, which is a subcategory of physical activity, the benefits can be up to 10-fold. So exercise is a subset of physical activity, but it's a bit more planned, it's structured, it has a bit more repetitive nature. And we tend to have goals or objectives that we want to achieve through exercise, like maintaining fitness. So I tend to say, when I'm walking around the wards, I'm very much being physically active. But when I lace up my shoes and do my training for my half marathon, that's me exercising. So there is a difference between both. And I think we need to maybe look at both as kind of two separate bits during our day. And I'll mainly focus on exercise rather than the physical activity. So as I said, both are important for your health benefits. But as I said, I'm going to mainly focus on exercise. So today I'm going to talk about two main types of exercise. Aerobic exercise or cardiorespiratory exercise is the one that we most commonly know. This is full body movements, something oftentimes in a repetitive nature, like walking, cycling, swimming, dancing, anything where the majority of our body is moving. This is where you start to feel your heart beating faster, your breathing increases. So this would be typically what most people would consider as exercise. The guidelines recommend 150 minutes of exercise or aerobic exercise per week. So if you break that down, 150 minutes seems like quite a lot, but if we break that down, that's 30 minutes, 5 days a week. And you can even break that down further. It could be 15 minutes in the morning and 15 minutes again in the evening. As I said there, you can break that into smaller chunks if you find that more manageable. With any type of exercise, we need to think a little bit of a formula. And if we're considering aerobic exercise, the formula would be how many minutes, what type of exercise. As we said, it was whole body movements. And then we need to think about what intensity we work at. Like I said, if we're pottering around the house or we're doing maybe some daily tasks around the house, that might be a little bit at a lower intensity. For it to count as aerobic or kind of exercise, it needs to be at a moderate intensity. It's an often thing you might hear physiotherapists saying is you can still talk, but you can't sing. That's generally what we consider a moderate intensity. Or a lot of people maybe through pulmonary rehab would have seen these scales of how breathless you are on a scale of 0 to 10. In around that 3 or 4 is that sweet spot where we're exercising at the right intensity to elicit change in our body that we will get fitter, but we're not working too hard that we have to keep start and stop. Okay. Again, if any of my patients are here, they'll often hear me saying, just keep it really steady. You might do a warm up for a couple of minutes that brings you up from that 0 up to a breathless of 1, 2, maybe 3. And then when we get to that level of maybe 3 or 4, we keep it nice and steady for that maybe 15 to 20 minutes. And then as we are finishing that 20 minutes, we perhaps do another maybe 2 or 3 minutes of reducing that breathless or reducing the intensity back down to where our breathing has come back to normal. So if you know any of those kind of famous athletes, I want people to think about being maybe a little bit more like Mo Farah, who is a long distance runner, doing marathons or long distance, and maybe not like Usain Bolt, who is running really, really fast for a couple of minutes, or not even a couple of minutes, a couple of seconds, and then stopping. So think of longer endurance rather than start and stop, start, stop. And this can be a variety of things, and I think it's really important to remember, you need to do something you enjoy. Like it would be going for a brisk walk oftentimes, and I know a lot of our patients have an exercise bike at home. It could be a dance class, it could be a Zumba class, it could be anything that you enjoy. And I know ILFA have a fantastic class 3 times a week as well, which I refer pretty much all my patients to. So it's a fantastic facility to avail of. But I think the most important thing is something that you enjoy. And then the second kind of group of exercise that I'm going to focus on today, or style of exercise, is what we call strength exercising or resistance. And this is often one that perhaps maybe gets a little bit forgotten about, or maybe just is not as much focus on. And this is where we apply an external resistance to a particular body part or a movement to elicit resistance, and that the muscle that we're targeting to become stronger. So that could be through TheraBands, those elastic bands, dumbbells. And I suppose I'm a little bit on the agenda or hunt to try and maybe push patients to get to the level where they're using dumbbells and maybe not water bottles or tins of beans, because that resistance is probably not enough to elicit a change. So we need to challenge ourselves enough for the exercise to actually work. Again, there's a formula involved with the exercise. So if we're not using heavy enough weight, then we're not going to reap the benefits of doing the exercise. So the guidelines say it needs to be a minimum of about 8 exercises, and this is a mixture of upper body and lower body. Again, part of the formula is we do it a minimum of 3 times a week. So I'd often tell people to maybe do it Monday, Wednesday, Friday, so that you have a rest day in between, rather than doing it Monday, Tuesday, Wednesday, and having the rest of the week off. Again, part of the formula is how many do we do, or how many repetitions do we do? So with these exercises, we don't look at time. We look at how many times we repeat the exercise. So we recommend doing each of the exercises roughly around 10 times. And then we take a break after 10 and we repeat that 3 times. So rather than accumulating all the repetitions into 30, it's 10, take a break, 10 again, and then 10 again. So it's really specific, because if we're able to do it 30 times in a row, the exercise is probably too easy. We need to use a heavier weight, that by the time we get to number 10 or 12, you're saying, oh, that's getting to kind of moderate to hard. I need maybe 30 seconds to 60 seconds break before I do the second set of 10, again, the third set of 10. So that's really important, that we're not doing it for time and that we're doing it for repetitions. And if you find after a couple of weeks of doing it, the 10 starts feeling a lot easier because you've got stronger, then we need to invest in maybe a little bit heavier weights to make the exercise harder again, because you've just got better and stronger. As I said, it should feel moderate to hard at the end of the 10, 12 repetitions, and you should need to take a short break. The most important thing with these is take your time. It's not about pushing really fast and doing the exercise really quickly. Oftentimes doing them slower elicits a better resistance. And I've just written a couple examples like bicep curls, squats, shoulder presses, and heel raises. There are a couple examples of some really simple ones that you can do at home. I think it's important as well to look at some other exercise routines that maybe people might like to get involved with, aside from your aerobic and your strength. Some people might find some flexibility work or some meditation work like yoga and Pilates really helpful. And I know ILFA do a fantastic yoga session once a week. And this can help as well with like mindfulness and meditation. There's definitely some brilliant resources that ILFA have online. So I'd recommend checking out their website. Something that I found, I listened to talk really recently by Dr. Roisin. She has some fantastic evidence around the Sing Strong programs that she runs throughout Ireland. And I know ILFA have worked really closely with her with this. I think the benefits from doing something as simple as joining a choir or a kind of a singing class, there's some really good benefits from that as well, from a mental health point of view as well. I think it's important as well to look at oxygen when we're talking about exercising. So as Prof. O'Regan mentioned, some people might not be prescribed exercise or oxygen, sorry. So please maybe just take this as a case by case. Oftentimes people are recommended 2 levels of oxygen. For some people that might be nothing at rest when they're watching TV or in bed, and then they might be using oxygen only when they're moving. So it's important to have kind of clear guidelines from your physiotherapist or your nurse or your doctor about what levels of oxygen you should be using and what are your target sats, like Dr. O'Regan mentioned. So if you're exercising, it's very important to use your oxygen as prescribed. Okay, so what did your physiotherapist recommend when you're exercising? How much should you be using? It's not a matter of I'll put it on for the first 20 minutes and bank up some oxygen from the canister or the concentrator and then take it off for the last 20 minutes. We need to be using it throughout the exercise. If we're using oxygen, I would recommend when you're within your house to use your concentrator. That will leave you with a better supply of oxygen for your portable version for outside of the house. So use your concentrator for doing your online classes like ILFA, maybe when you're walking around the house, when you're using your exercise bike, or when you're completing your strength exercises like I recommended. So always use your concentrator while you're doing these, so then you have a good supply of your portable oxygen while you leave the house. Then outside the house, this is when you use your portable oxygen. That might be your liquid oxygen, your cylinders, or your Inogen, or your portable concentrator device. So then we'd be recommend to use them outside of the house. And as I said, if it isn't clear for you about your oxygen prescription, please seek advice. Okay, don't be at home wondering what should my oxygen levels be, or how much oxygen should I be using. Please seek advice from your physiotherapist, from your doctor, from your nurse, to make this clear, so that you have kind of clear guidelines at home so you can exercise safely. And I think I'm just going to finish with some do's, because I want to be really positive around exercise. And as I said, do complete a warm up and a cool down, just so that you feel comfortable before and after exercise. Do see exercise as a way to help you feel strong and fit. I think this is really important, that we see exercise as a way of living a healthy lifestyle with a good quality of life. I was just talking to a transplant patient, and I said, I want exercise to be that vessel, or that avenue of going and enjoying a full and active day with your family, because you're fit enough and you're strong enough to do that. I think the more we incorporate exercise into our daily life, it gives us more opportunity to have energy and, I suppose, vigor to go and enjoy maybe a day out with your family, or a nice meal with your family, because you're fit and strong enough to do that. And for me, that's the most important thing that exercise can give you. Do exercise that you enjoy. There's no point in doing stuff that you don't enjoy, because you won't do it and you won't comply with that. So get your family involved, start a walking group, get involved with a class, do whatever you enjoy. And that's really important, because you're more likely to do it then. Do use your oxygen as prescribed. And as I said, seek guidance if this isn't clear for you. If you really don't have a grip on exercise, or just really don't know where to start, seek advice from your physiotherapist. Ask your doctor to refer you to your physiotherapist or healthcare provider, and we can really simply give you a tailored programs to suit you. And that's our job and that's our role, and we're more than happy to help. I think it's important as well with exercises, do set small goals and challenges, because this will help keep you motivated. It's really difficult to get out there some days, but if you really start to notice a change in how you feel by setting little goals and reaching them, it's much easier to complete your exercise program. So set small challenges. That might be a step challenge, and I know ILFA have a great pack, the 2000 step challenge, and this might be something that you get your family involved as well, small little challenges like that. I know many people have kind of step counters on their phone or their watches. So set little small targets and then just keep pushing yourself on, because that's what it's about. And as I mentioned already, do check out the ILFA classes. I think they're an absolutely fantastic resource, and it's so nice to see the demand has gone up for these. So check them out on a Monday, Wednesday, and a Thursday. And anytime I see any of my patients' little face on those videos, it just really makes me so happy to see you being involved in that. And thanks again to ILFA for providing such a fantastic service for all you guys. So I'm happy to take any questions now. If anybody has any.
You just have one there that's come in just at the very end. Is rowing a good exercise, Olive?
Yeah, rowing would be classed as an aerobic exercise. It can be a little bit tough for people with a lung disease, as you're using your upper body mainly. So it can be a tough exercise for those people, but I suppose if you want to try that and you enjoy that, you could maybe keep the resistance low. And again, you're working at that moderate intensity. So I don't think there's any exercise that you shouldn't do. But I think maybe considering ones that you maybe will comply with and enjoy. So if you enjoy rowing, then please, if it's safe and you're happy to do it, then I think it's a fantastic idea.
Well, thank you for that. And thank you to Anthony in the background. That's been busy answering questions that's been coming in. Conscious of time, because we'll move on. Thank you, Olive, and well done again on the marathon. Back to you,
thank you.
Eddie.
Thanks a million.
Great. Thank you, Olive, for a great presentation and lots of really, really good tips. Thank you so much. Our next speaker is Patricia Davis, and Patricia is an advanced nurse practitioner in respiratory integrated care in Wicklow. Patricia has a special interest in oxygen and is part of the HSE funded respiratory therapies group. Patricia's presentation is called Oxygen at Home and in the Future. So I'm now going to hand over to Patricia. Thank you.
Thank you, Eddie, and thank you everyone for inviting me to speak today. I've had great involvement with ILFA over the years talking about oxygen, so it's a great opportunity to talk to you all again today. I'm just going to share my screen. Sorry now. Oh, there we go. So I was just going to start today to talk about the criteria for being prescribed oxygen. Professor O'Regan has alluded to some of it here, and realistically, it is a little better if you're seen by a specialist when you have your assessment for your oxygen. The most accurate way to assess a person's oxygen levels is often with an arterial blood gas sample, and you can see this being undertaken here in the photograph. The sample does have to be analysed within 30 minutes, so it cannot be carried out in your GP practice. It measures the actual level of oxygen in the blood when you're at rest, if you're breathing air or breathing oxygen. And while it's a very useful test, we also very much rely on oxygen saturations as well, particularly when patients are walking and doing walk tests. We have got guidelines surrounding the prescription of oxygen and you know, how and when somebody should be prescribed oxygen, and these are based on some clinical trials that were done a number of years ago. But the trials were done on people with COPD. So there is trials ongoing around oxygen in people with lung fibrosis, but as previously alluded to, the expert opinion really is that people should be supplied with oxygen where they're desaturating below 90% on a walk test if it is likely to add to their quality of life. So if it's a thing that you are desaturating down even as much as 85, 88%, and there is no difference to you in terms of the distance that you walk, the symptoms that you experience, then quite often, as Prof. O'Regan suggested there, we don't provide oxygen therapy unless it is going to add benefit to your quality of life, because it does change things in your day-to-day life, and it is an additional thing to have to consider in your day-to-day. So when we prescribe oxygen then for exercise, there's no strict rules when it comes to titrating someone's oxygen levels on exertion, and it can take several trials and tests to kind of try and get it right. And then sometimes, depending on how your disease is progressing, we may need to reassess it, every couple of months, or depending on, how you're feeling. Not every single piece of equipment is suited to every person. This is why it's essential that you are assessed by staff that are very familiar with all of the equipment that's available to you when you are walking and you're exercising. Sometimes we do struggle in people with fibrosis to maintain their oxygen levels greater than 85%, even with 10 litres of oxygen. So sometimes we may need to prioritise your comfort and whether the oxygen is actually working for you, and have a very open and honest conversation about what your priorities are. So if we can know what's really important to you in your day-to-day, and what activities you'd really like to do, and what you need, then we can prioritise that. And there are low oxygen levels don't automatically mean that you're going to be breathless. So I would have people come to me with low oxygen levels who experience no breathlessness, and people with normal oxygen levels who experience very significant breathlessness. So it's a very individual thing, and breathlessness does not always correlate with the oxygen levels, which means that oxygen doesn't always relieve breathlessness either, and you often need alternative tools to help you with that. And I often say to people, you're like Batman with a tool belt, and you've got all these different tools that you're going to tap into to help you to control your breathlessness. And oxygen is just one of those tools that we use. ILFA developed the stall breathing technique, which can also help. And we use things like a handheld fan rotated around the face to alleviate breathlessness as well. So it's important to discuss all of these tools that you might be able to gain and learn about with your physio and your nurse within your clinics, and they can certainly help you with these. So exercise with oxygen has already been addressed very well there, and sometimes low oxygen levels can affect how hard your muscles can work and how long for, and you may find that you tire a little bit more quickly. So in some situations, particularly perhaps during pulmonary rehab classes, whereby you're exercising at a higher intensity, you are sometimes recommended to turn up your oxygen levels during those particular situations and then reduce it back down when you've recovered. We don't have any high quality studies on the long-term impact of low oxygen levels, but the indications are that it doesn't have an impact on mortality or disease progression. So if you are doing regular high intensity exercises and your levels are constantly dropping below 85, the equipment type may not necessarily suit you. So you may need to be reconsidered for perhaps liquid or cylinder oxygen, particularly if you're on a portable oxygen concentrator. The new American Thoracic Society guidelines suggest that anyone requiring greater than 3 litres of oxygen should commence on liquid oxygen. I personally feel this is really down to an individual assessment based on your own needs at the time. And strength and conditioning exercises, as was highlighted, can be just as useful as cardio exercises and may require less oxygen to undertake as well. So there's lots of different modalities, and you know, as technologies develop and things like that, we should see in the future more and more different types of modalities, and it feels like the portable oxygen concentrator market has really increased significantly over the years. They all come with pros and cons, and there isn't one size fits all. There's no perfect piece of equipment, and unfortunately people feel, you know, a lot of the time people want the smallest device possible that they can carry on their back that's going to give endless supplies of oxygen, and unfortunately we just don't have that. So ambulatory oxygen can be cumbersome and, you know, difficult to manage at times, and it takes practice and it takes a bit of time. And then, you know, when you have a lung disease and you're on oxygen therapy, you're wearing your condition outside where people can see it and might ask questions, or, you know, so it is something that sometimes people can feel a little embarrassed by. So having very open conversations again with your physio or nurse or whoever's in your oxygen clinic about what your priorities are and what's important to you, and how you transport that oxygen, we can try and accommodate as much as possible. So we have the ambulatory cylinders and pulse dose. So these are these little devices here are conservers, and they conserve the amount of oxygen you might have in your cylinder, for example. So you'll hear the oxygen being administered, and it's only every time you take a breath. So the oxygen will start to go psh, 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 every time you take a breath in. And that's really to conserve the amount of oxygen in your cylinder. So for example, if you're on 2 litres and you have a standard size cylinder, it should last about 8 hours with a conserving device, but without the conserving device, it might only last 2 to 3 hours. We also have these oxygen concentrators, which are the larger machines that are out in the house. These run on electricity, so there is no oxygen contained within the machine. So when it is switched off, there is no oxygen within the machine. They work by extracting the nitrogen from the room air, and they concentrate it down and provide you then with the oxygen. And they come in a standard size, which goes up to 5 litres per minute, or a high flow that goes up to 10. But we do have situations where people are over 10 litres, and we will buddy up the 2 machines together with a Y connector tubing. Liquid oxygen, then you can see here as well to the right, you have a mothership, I think, that looks a bit like a Daleks, Doctor Who, and that's filled by the company. So they fill that with liquid oxygen, and then you, as a person that's using the oxygen yourself, you come along with these smaller little devices or flasks, and you top up the flasks yourself. And you're supplied with 1 or 2, depends on your requirements and how many litres per minute you're on. and they can only be delivered. There's lots of different criteria around them. So things like, you know, they can't be delivered into a first floor of a house or an apartment or something like that. So there's a lot of factors involved in having that installed into your home, and they are primarily used for outside the home. So if you're for ambulatory kind of use outside the home. And then we have the smaller portable oxygen concentrators, which are easier to carry. They are similar to the larger concentrators in that they don't contain the oxygen, they generate oxygen. They are battery packed, but they can be plugged in for charge. And again, they are kind of pegged as easier to use, but they are unfortunately, the batteries can run out quite quickly if you're on a higher level of oxygen. So if you're on high amount of oxygen in terms of liters per minute or settings, which is what the POCs come as, they aren't wonderful, and oftentimes you end up needing to go on to cylinders or liquid oxygen. So that's a whistle-stop tour of the modalities. There are nuances and different types as well, lots of different devices around. So in terms of kind of trying to manage your energy levels when you're using oxygen, our occupational therapy colleagues can help with talking to people about managing their energy levels. And this, can help you to manage your fatigue that might be associated with your condition. So we'd often say to prioritize things. So if there's anything unnecessary that you need to do that day, to cut it out. So if you know you've got a hospital appointment on a Tuesday, that you maybe have your shower the day before and not the day of it, so that you're not using all of your energy up in the morning before you can get to the clinic. Plan things. So what time of the day is best? When have you got your highest level of energy? That you can plan what you're doing at that time. If you want to bake a cake, that all of your ingredients are ready. So it's about planning everything. Actually, I get most of my tips from the people that I work with, or the patients that I work with. So I had a gentleman who always had a flannel dressing gown, which was towel, so he didn't have to worry about drying himself off and things like that. Shower seats are also helpful. Long handled shower brushes for scrubbing your back. Again, the more you're using your upper arm, the more your energy levels will go down. And discuss with your oxygen clinic or your physios or nurses, whether you can increase your oxygen for certain activities. Rushing, so people tend to rush when they're getting breathless. So you tend to, right, I'm going to get over to the side of the room as quickly as possible, because I know I'm going to get breathless when I do it. So we would recommend that people actually pace through things and certain activities, so that they and rest in between certain activities that might make you breathless. And make sure, if you are showering, you can bring your oxygen tubing in, but it's best not to bring things like the concentrator or the cylinders or things like that, because the devices themselves can get water damage. But it is perfectly okay to bring the tubing into the bathroom as well. So a lot of the time we get asked this question about whether you can turn up the oxygen a little bit higher. And yes, usually with interstitial lung disease, it is acceptable to increase your oxygen whilst you exercise, but it is best to do that under the advisement of your clinical staff. And oftentimes we'll do that titration during a 6-minute walk test to know what to raise it up to. So I have had situations whereby a younger patient of mine wasn't getting low oxygen levels or breathless on a walk test because he was very, very fit, but yet found at a certain point of the intensity of the exercises and the distance, so he did a lot of hill walking, at certain points he found he was becoming very difficult with his breathing, and so we gave him a longer monitor, so a 24-hour monitor, and we found that when he hit a certain point, his levels did drop quite significantly in his exercise. So we gave him a small oxygen tank just for that particular point to help with his recovery. So it is very much about titrating and individual assessment for every patient that comes into clinics, to make sure that the oxygen, if it is being provided and it is needed, is suitable for that individual person. So you may sit in a clinic and have a person beside you on a small little device, you're like, geez, that's so much better than mine, I think I should ask for that. But again, it's down to very individual assessment, and not every piece of equipment suits every person. So, and this again is where the breathlessness management techniques can really help in conjunction with your oxygen. If you have underlying COPD, it may not be advisable to increase the oxygen by yourself. So with COPD, it's a specific issue with the tubes. Going back to Prof. Regan's the images he shared at the start there. So with COPD or emphysema, sometimes there is a problem in the tubes, which can affect the airflow in and out of the lungs. So it is always best to check with your clinic before you increase your oxygen yourself. So we talk about oxygen levels at night time. So people are concerned sometimes if their oxygen levels are low during the day, are they kind of low during the night? So this is the 24-hour monitor that I was talking about here on this lady. And we can give you one of those as part of your oxygen assessment at nighttime to see, one, if you do need to maybe increase your oxygen levels at nighttime. But if your oxygen levels are okay during the day and they do dip a bit at nighttime, there's no real evidence to say that you actually really need oxygen at nighttime. If your levels and your arterial blood gas and your walk test are all okay during the day, if they dip a little bit at night, there's no real need to correct it. Now, if it does sometimes come up that people might have an underlying condition called obstructive sleep apnea. And if that's the case, that requires a separate assessment, so called a sleep assessment. But the staff that are assessing you will know that. And if they feel there's a risk that you could have sleep apnea, they will refer you to the appropriate clinic and the appropriate service for that. But overall, it's not necessary. And if it is a thing that your levels are dropping during the day and you're on supplemental oxygen and you're on oxygen at nighttime, sometimes they may well do an oxygen assessment like this while you're on your oxygen to assess to make sure that the oxygen that you are receiving at nighttime is sufficient. And the other thing people worry about sometimes is the oxygen could come off at nighttime because you use something on your face, and while you're asleep you might take it off. You can get small little plasters for your face from your suppliers, and you can just ask for those, and that'll just, they're better, they're kinder for the skin, and you can just feed your tubing into them. They use them on babies as well as adults, so it is something that you can ask for from your supplier. So in terms of the future of oxygen care, and Eddie alluded to this, I've been working with the community funded schemes group, which were put together to look at oxygen contracts, and not just oxygen. We looked at contracts for all products that people might use in the community, such as incontinence wear, dressings, all of that kind of stuff, to make sure that we were getting good access to quality products for people, and that every person across Ireland had access to the same equipment. So I've been working on that group for 8 years. It's taken quite some time to get everything together, and we've worked with ILFA and some representatives from other organisations as well, respiratory organisations and stakeholders within it, to try and get as much information about the things that matter to you, so that we can incorporate that into the service level agreements that we have with our oxygen suppliers. So we are hoping through this group, we hope to have national standards so that everybody has the same standard of care, everybody has access to the same devices, and that we have value for money for all of those products as well, because healthcare is expensive. And that the processes surrounding all of that equipment, the ordering of it, etc., is similar across the country, because there are different practices across the country, and that we have a management system in place to ensure that there is compliance from suppliers with all of those products and contracts as well. So in the recent contract was awarded. So you may not be aware, but Ireland is divided into CHOs, community healthcare organisations, and these are from 1 to 9. And so in order to reduce, to prevent one company having a monopoly over the country, the winner of the contract could only win 2 areas. So Air Liquide came top on the contracts, and they are going to be taking over all oxygen supply for area A and B. And it's probably easier to look at area C. So Vivasol is a new company coming in. They're a large company across the entirety of Europe and in the UK, and they're going to be taking over area C. So if you're in the counties there: Kerry, Cork, South Tip, Carlow, Kilkenny, Waterford, Wexford, Wicklow, South East, and South East Dublin. And you're currently having your oxygen supply from Aer Liquide or BOC. You will be transferred over in the coming kind of months to this company called Vivasol. BOC are no longer going to supply home oxygen therapy once the contracts are finalised and the handover date is agreed. Now, this feels like quite a big change for everybody, but we are fully confident that these suppliers, Vivasol and Aer Liquide, have a long history of experience and professionalism in the area of oxygen supply across, not only in Ireland, but across Europe and the UK. So we're currently working with all of the suppliers to ensure a smooth transition with that, and hopefully by this time next year we will see services very much embedded and everybody kind of sorted out. So we are taking time to get that transition going. Sorry. And as part of the agreements with the contracts, we have to have what's called a service level agreement, and this is an agreement between the companies and the HSE on the types of service and how their services are going to be run to an extent. So what we did was we brought in a lot of the stakeholders, so ILFA, the Irish Lung Fibrosis Association, the Asthma Society, COPD Support Ireland, and the Irish Asthma Society, the Respiratory Nurse Association, Physiotherapists came in together, and we discussed what we wanted as a service from these companies. So I've actually been writing on that this morning and incorporating a lot of the feedback that we got, and that will go to the suppliers for them to consider if that's something they can supply. And a lot of it is in existence already, and some of it is not in existence. So we are hoping to see improved services throughout this contract, and the contract will last for about 3 years with an option to extend it for 5 years. So what does this mean then for you? So at the moment, we know and we are aware that there is issues with supply of liquid oxygen in certain areas in the country. So we as part of this contract, it was essential that all people tendering for it were able to supply liquid oxygen to ensure that all liquid oxygen would be available to all patients regardless of their location. As I previously said, if you live in Area C, your supplier will be changing to Vivasol. You will be contacted about that. Your equipment at home most likely won't change unless it breaks down or there's an issue with the cylinders or anything else like that. And then it will be handed over. You will be supplied with new equipment from the new supplier. But potentially the person who maybe drops off your cylinders might change, and you'll get a new phone number to ring for your cylinders. We do hope that in time, as part of this, you will potentially be able to order online or from an app or whatever. So we are encouraging the companies to do a little bit more around digital, and as clinicians, we will be able to order digitally, which will hopefully speed up the process. If you live in Area A or B, and your oxygen is supplied by BOC, your supplier will be changing to Aer Liquide as well. And Aer Liquide currently don't supply liquid oxygen, but as part of the tender, they will. So the number that you call then, obviously, as I said, for cylinder refills may change. Currently in the HSE, there was a stipulation that your basic cylinder allowance, so once your first ordered oxygen, you were only really allowed 6 cylinders per month. So I've now changed it to the standard is 8 cylinders per month. But if it's a thing that you're in your clinic and the physio or the nurse that assesses you finds that you require maybe say 5 litres a minute, they can automatically put you onto a 12 cylinder per month allowance. So this is definitely something that is more positive for people with pulmonary fibrosis, because quite often they have to start on a higher amount of oxygen. So instead of having to go back to your clinic and ask for, because each time you needed an increase in your allowance, you needed a letter from your clinical staff. So now this enables them to start at a higher amount of cylinder allowance. So there's lots of positive changes with it. please bear with us. It is going to take a bit of time, and there will be some hiccups along the way, but we are hopeful that this is an extremely positive change for the future of oxygen supply to all people across the island of Ireland. Sorry now. So I just wanted to kind of bring it back now to when you're first ordered or first told that you might need oxygen. It is a new point in your disease progression, and it is something that can be a little bit overwhelming. You receive a lot of new information, the equipment comes to the house, you get told a lot of information about it, and it can be quite daunting. And there's a lot of feelings around that. And for some people, there's grief, and for some people, there's relief. And it doesn't really matter what the feelings are, they're all normal, and it's important that they're acknowledged. But if you do have continued feelings throughout of depression, it might be worthwhile speaking to your GP for additional mental health supports. I work very closely with my GP colleagues out in the community, and they have a huge amount of understanding when it comes to mental health issues. So if it is something that you are struggling to cope with, that you can obviously talk to your clinical staff within the hospital or in the community, but your GP is a really good resource as well for mental health support if you need it. Worrying about oxygen levels and low oxygen levels is completely normal at this point in your condition. And I know Prof. Regan has mentioned this, and Olive has also alluded to it, that, you know, low oxygen levels are not detrimental. It is not something to be too concerned about. And the safety of the low levels is really relative on how you feel. If your levels are low, but you feel fine, it's okay. You know, short periods of low oxygen levels is not harmful. Sometimes people get very panicked when their oxygen comes off because they feel something detrimental or dreadful is going to happen when their levels are low. And, you know, it may not happen. So, and it's important. Yes, it may affect your performance and your symptoms a little bit, but for short periods of time, it's actually okay. And we often recommend people do take rests from their oxygen to give their nose and their ears and things a rest, because you can get little pressure sores and things in your nose and on your ears. If you do have persistently low levels despite being on your oxygen therapy, then maybe talk to your clinic, your physio or your nurse about getting a reassessment and about your concerns, and contact them. And then obviously we've got lots of places for support, and ILFA is definitely a great resource. And as I've said, your respiratory nurse, your physio, your consultant, their team, the oxygen clinic staff, rehab team, your community staff, your GP, friends and family. And there are some kind of British and European websites with some further information as well. So, thank you very much.
Welcome back, everybody. We are now heading for our fourth speaker today. We will proceed with a short presentation highlighting some of ILFA's valuable work in the research field. Joining us from County Kerry is Sean O'Shea, who is chair of the ILFA Public and Patient Involvement Research Advisory Group. So with that, I'll hand over to you, Sean.
Thank you for inviting me to speak, Eddie and ILFA. So, I'm a patient with pulmonary fibrosis, and I'm speaking today as chairperson of the Patient and Public Involvement Group, which is also known as PPI Group within ILFA. ILFA aims to provide research, education and support for patients and carers of pulmonary fibrosis, also known as lung fibrosis. As part of its research initiatives, the PPI Group was established last year, and we had our first online meeting then in September. PPI goes towards ensuring that patients and carers' perspectives and their priorities are represented in research projects that will focus on pulmonary fibrosis. This will ensure that the patient's voice and their experience, as well as what they feel is important to them, are represented in the research. We need to understand the purpose and goals of the research project so that there is no confusion in the language or grammar used. As members of the PPI group, we can be further involved in the research process outside of the regular meetings by offering our opinions and health experience by directly participating in individual research projects. This latter involvement, however, is a purely optional choice for each PPI group member. However, we need to request more members to join our PPI group. We are short of our optimum PPI group membership. I'll just give a bit of brief on how we operate. The PPI group meets online approximately once every 4 months. We've had 4 meetings so far. The first requirement to be a PPI member is the ability to use online meeting technology. Anybody listening to me today has already satisfied that requirement. It would also be helpful if a member can receive and send emails and read email documents. The more PPI group members that we have, then it will enable a bigger and more representative voice for pulmonary fibrosis sufferers. And it will provide the researchers with information direct from actual patients and their carers. Please join our group if you're able. We need you. That's what I want to say. Over back to you, Eddie.
Thank you, Sean. Yeah, very enlightening. And I would ask people to consider joining the ILFA PPI Research Advisory Group, because an extra voice does matter and will help influence research priorities. Thanks again, Sean. Our next speaker is Lindsay Brown, Respiratory Advanced Nurse Practitioner at St. Vincent's University Hospital. Lindsay is a member of the ILFA Board of Trustees, and we are grateful to her for all her help and advice to ILFA over the years. Lindsay's presentation is entitled Accessing Specialist ILD Care. I'll hand over to Lindsay now. Thank you.
As Eddie said, I'm being asked to speak to you about accessing specialist ILD care, but really tell you of that. So in terms of referrals to the interstitial,
we're just having a bit of technical issues there with you, Lindsay. I don't know, are you able to move location there a bit? Just
okay.
You're a bit better there. Your internet.
Okay.
Yeah, I can hear you better now. Yeah.
The interstitial lung disease service at Vincent's are via written referrals. Unfortunately, we don't have a national electronic referral system as yet, like you would have for perhaps lung cancer services. So our referrals can either come via GP letter, where our individual respiratory physicians in interstitial lung diseases will triage those letters. That means to prioritise them. Otherwise, some of our referrals come through our emergency department, where someone has presented, say, for example, with a chest infection or perhaps chest pain and has undergone some radiological imaging, and that showed an incidental finding of an interstitial lung disease or a suspected one. We get referrals from our own general respiratory physicians seeking specialist ILD opinion. And we also get referrals through other specialisms, such as rheumatologists, where people with joint issues may develop associated interstitial lung diseases or skin diseases, or people with underlying heart disease. Similarly, some of our patients come through the rapid access lung cancer services, whereby they've been investigated for a malignancy. This has not been found, but an ILD has been found instead. Or it may be that you've been admitted and you get a subsequent follow-up in our clinic. And we also get referrals from regional hospitals seeking an ILD viewpoint. And similarly, some interstitial lung disease respiratory physicians also seek second opinions. Next slide, please. So in Vincent's University Hospital, the personnel that we have available to provide the service include 3 ILD specialist consultants, 1 consultant rheumatologist, 1 histopathologist, that's an expert in tissue samples, 2 consultant radiologists. We have 8 registrars attached to our ILD clinic, 4 of whom are specialist registrars and 1 respiratory fellow. And we're quite busy with our clinics. As you can see, we have a fortnightly complex ILD clinic with about 35 to 40 patients in attendance. We also have a rare lung disease clinic monthly with 25 patients. And we have a combined connective tissue disease and ILD clinic every 2 months with 15 to 20 patients. And I have a nurse-led ILD clinic every week with about 6 to 10 patients in attendance. And we also have liaison with the Mater Hospital, where we have a lung transplant MDT, and we closely liaise with them. Next slide, please. Okay, so in terms of numbers, we have 200 new patients referred annually, and we currently have 600 ILD patients presently attending, and also 200 rare lung disease patients. Next slide, please. Okay, according to the European IPF Charter in 2016, patients with IPF should require long-term care from specialised healthcare professionals to address their multidimensional medical, pharmaceutical and psychological challenges. And the initial challenge is one of diagnosis. Next slide, please. So challenges in diagnosis and prognosis in ILD occur because ILD refers to a diverse group of disorders characterised by degrees of inflammation and scarring of the lung. The diagnosis is challenging due to the fact that there can be unusual or atypical or overlapping patterns on radiology or histopathology, differing disease courses and rarity of some of the diseases. And 10 to 20% of cases can remain unclassifiable. And that's why a multidisciplinary team meeting is the gold standard for diagnosis, because many patients are at risk of prognosis of fibrotic disease with reduced quality of life and premature mortality. And early recognition and timely initiation of disease-specific therapy are important determinants of outcome. So antifibrotic therapy has been shown to slow disease progression in IPF, but it's also now been shown to be effective in non-IPF progressive fibrosing ILDs, as in the InBuild and Census trials. But also other non-IPF ILDs respond to immunosuppressive therapy. So early and accurate diagnosis is critical. Next slide, please. So if we look at this slide, and I don't know if it shows up very well, but the bottom box in this is about the outcome of the ILD MDM. And basically, what we're hoping to achieve is agreement or consensus in diagnosis, and confidently. But if there isn't a clear-cut diagnosis, then there's an indication for further investigation, and those then are subsequently actioned. You need to look at the expected disease behaviour to see if it's manifesting as you would expect. And then there are decisions made about the management of the underlying disease. So what treatment options have we got available? Are they specific to the disease process? Perhaps inclusion in clinical trials that are running, or transplant referral if appropriate. And where there's an indication of advanced disease, it may involve referral at that point to palliative care. Next slide, please. Thank you. So this slide indicates the needs of patients with interstitial lung disease, and they are highly individual and vary throughout the disease course. They include timely and accurate diagnosis, access to pharmacological and non-pharmacological interventions, pulmonary rehabilitation, supplemental oxygen therapy, nutritional and psychological support, disease-related education and awareness amongst the public needs to be raised, but also amongst healthcare professionals so that we get early referrals. And also awareness of the burden of ILD, it aimed at alleviating symptoms and reducing the impact of the ILD on patients, families and their caregivers. So comprehensive care is designed to meet those needs, should focus on collaboration and trust among patients, families and healthcare teams. Thank you. Next slide. So a study by the EU PFF by Moore in 2019, over 18 EU countries was surveyed, And they found that findings that patients with idiopathic pulmonary fibrosis had insufficient information and support, which led to problems with self-management. Next slide, please. I think it's one back. Thank you. So the specialist ILD nurses, they play a major role post-diagnosis of giving information. They're able to do so in a clear, concise way, giving accurate, up-to-date information pertinent to a specific ILD. They can provide written reference material to support their input, and they can direct you to online resources and patient support groups, such as ILFA, but such as other support organisations like the LAM Foundation, PAP Foundation, ISARC for sarcoidosis. The other thing that the ILD nurses provide is something that we term unscheduled care, and that's by virtue of their availability, so they can be readily accessed via email, text, pager or telephone. And the ILD AMP clinic that I run can facilitate a face-to-face visit, usually within a week of a call to address issues arising. But we also can undertake what we call virtual review over the telephone to offer advice and guidance. The nurses also have a major role to play in referral to allied health professionals, such as pulmonary rehab, dietitians, and we also now have the opportunity to refer to a Boehringer Ingelheim nurse who've been employed to support patients that are started on OFEV, one of the antifibrotics. Next slide, please. Thank you. So I recently undertook an audit of the interactions that I had in 2022, and I had over 1,700 AMP consults. That includes face-to-face and virtual. I also had 631 indirect contacts and 767 unscheduled calls to the service. And if you look at the nature of the calls, they were very varied, but they may have included issues around oxygen therapy, worsening symptoms, reducing exercise tolerance. Sometimes it was family concerns about whether someone should be referred to palliative care because their symptom burden or their level of breathlessness had increased substantially. So next slide, please. So one of the key roles then for the AMPs and part of the ILD team is that of monitoring symptom burden and disease progression. We also look at the spirometry and diffusion capacity trend, which Professor O'Regan mentioned, and we're looking to see if there's a greater than 10% relative decline in FVC or a greater than 15% relative decline in DLCO, which would indicate progression of disease. But obviously we don't take that on one reading. We have to do a couple of readings at least to see that that's a true reflection. Similarly, we monitor someone's exercise capacity. Now, some of that's self-reported, but some patients have Fitbits and they can measure their step count. We also look at increase in oxygen requirements. We look at how we can offer psychosocial support to patients. And certainly some of the hospitals do cognitive behavioural therapy, as ILFA has trained those nurses in that capacity. And the other thing that the nurses do is monitor patients' bloods and drug tolerance and offer advice regarding dose titration and also managing adverse reactions. We also offer transplant case management in relation to patients that have been referred for transplant, and we do that with a monthly phone call to establish how the patients are progressing, and if we need to see them as a matter of urgency, we can arrange that. And similarly, we also offer remote patient monitoring for a small number of patients in specific cohorts. Next slide, please. Okay, so I'm not going to dwell too much on this because you've had absolutely excellent input from Olivia McCafferty already about the importance of exercise. But just to say that pulmonary rehab has absolutely marvelous benefits, including reducing fatigue, improving your walk distance, improving your quality of life, lessening your experience of breathlessness, and it's done through aerobic and resistance training, as Olivia said. But the benefits can be seen if someone completes 80% of sessions. and that's associated with a 30% survival increase. But early referral for pulmonary rehab is very important. And similarly, some of the benefits may be maintained at 6 months following the programme. Unfortunately, in Ireland, as it stands, there are regional variations in the provision, and location for some patients can be too far away, particularly if you've got the burden of carrying oxygen. Also, they were set up on the back of the national COPD programme, and they tend to focus on COPD, so the education may not be ILD specific. They give limited caregiver or family support. They can have challenging access in that you've got to access them via stairs. So it's absolutely marvellous that ILFA provide the online tele-rehab, which evidence suggests is safe, clinically meaningful in that you get gains in quality of life in 6-minute walk test, physical activity for severely breathless patients. But some 20% of our patients might be unsuitable because of falls risks, because of cognitive decline, because of other underlying health conditions like pulmonary hypertension, or personal preference that they want to go to a hospital-based class. Next slide. Next slide, please. Next slide. Thank you. So in terms of oxygen supplementation, we know that low oxygen levels are prevalent in patients with IPF, and the primary goal of supplemental oxygen is to protect organ function, improve exercise capacity, but it may not translate into an improvement in quality of life or daily functional ability. Similarly, patients can have low nocturnal oxygen levels, and that can occur even if you've got daytime level satisfactory. That can be perhaps associated with pulmonary hypertension and poor prognosis. So given overnight oxygen may prevent or slow down the development of pulmonary hypertension. And the pulmonary hypertension experts would suggest that oxygen be prescribed if SpO2 is less than 90% for more than 10% of total sleep time. Next slide. So the challenges of oxygen, I'm sure my colleague Patricia Davis has spoken about this, but I would reiterate, it's got to be assessed on an individual basis. A patient has to feel that they get a symptomatic benefit from being in oxygen. If it poses a burden that means that they don't want to leave their home, they become socially isolated, and that their exercise capacity reduces, then oxygen may not be a viable option for that person. It's more of a hindrance than a help. The equipment may be heavy. Patients need education on the operation of these devices, and that might need to be reiterated. Some devices are not suitable for patients if they mouth breathe, such as some of the portable oxygen concentrators. Getting adequate supplies can be an issue. Delivery timescale can be an issue. There's a fear of patients running out, or the embarrassment of being seen outside on oxygen therapy, and there's this perceived prognostic implication. Similarly, there can be travel issues because some patients early on in disease still want to fly, and therefore there's a necessity to meet the flight assessment criteria. Next slide, please. So one of the other key issues in terms of what we do at clinic is about symptom relief. And we looking at 4 symptoms: breathlessness, fatigue, anxiety, depression, and cough. So breathlessness and fatigue have been shown to be helped by pulmonary rehab. But also we can refer patients to breathlessness clinics that are run out of some of the hospices. So they're run by palliative care, and they're multidisciplinary with a psychologist, an OT, a physiotherapist, and a palliative care nurse. And they can have huge benefits in terms of breathlessness mastery and also survival advantages. They improve, they can perhaps consider starting someone on an opioid, so that's a morphine-based drug, which can improve shortness of breath at rest, but doesn't tend to be associated with increase in hospitalisation risk, which is a good thing. There's another drug called a benzodiazepine, which helps to reduce anxiety, but it is associated with potential increased hospitalisation at higher doses, so that needs to be used in caution. As I said, fatigue's helped by pulmonary rehab and also oxygen. And if you reduce fatigue, then it can improve a patient's fitness level, improve their sleep, reduce the psychological distress, and help reduce tiredness and exhaustion. In terms of anxiety and depression, this is something that we need to be better at asking our patients about and screening them better at, in terms of at baseline, how do they feel, and at intervals to see if there's any mood disturbance. Certainly cognitive behavioural therapy can help that, and the use of individualised care plans. And in terms of cough, one of the key things there is to treat other underlying problems such as gastric reflux from the tummy, nasal symptoms like a postnasal drip. There's some evidence that immunosuppressant drugs can help in connective tissue disease like scleroderma. Pirfenidone has been shown, which is an antifibrotic, has been shown to reduce cough. And there's evidence to suggest that a drug called sodium chromoglycate can reduce cough frequency and is well tolerated and can help improve health-related quality of life. Next slide, please. So this is just an illustration to indicate the effect and survival of breathlessness if you get referred to a breathlessness support service, so a clinic. So the red line is those who were referred to the breathlessness clinic, and the blue line are those who were not. And it's looking at basically the days from consent and the patient survival. So you can see that there's a clear survival benefit in being referred. Next slide, please. Okay, so the other thing that's really crucial in our clinics is end-of-life care, because with interstitial lung diseases, the prognosis is very variable and is unpredictable, with the risk of exacerbations, which may be infective, and the possibility of rapid deterioration in the condition. But this subject can be very difficult to discuss, both for a patient, their family, their caregiver, and for the healthcare professional. But it's crucial that timely, thoughtful conversation is undertaken, because it can help patients explore their fears, their needs, their beliefs, and their preferences. Now, specialist ILD nurses are skillful in discussing this sensitively and compassionately, and allowing patients time to reflect on how and when to proceed with palliative care referrals. And you can be referred both as an inpatient to palliative care or to our community colleagues, and this can reap dividends. There are also literature, it's been published by the Irish Hospice Foundation, called the Thinking Ahead booklet, which is very helpful. It's very comprehensive, and it's easy to sit down with your loved ones and to go through it, and so that everyone knows your wishes. And also there are advanced care directives, and those can facilitate contemplation of this aspect of care. Next slide, please. So the other issue that's quite important with patients with ILD is that if you've got exceptional breathlessness and you're working hard to breathe, it can result negatively on your nutritional status, because you may not be eating large meals, you might not be eating as well as possible. So the disease process and other associated medical treatments can negatively impact on this, and your exercise capacity, and your health-related quality of life, and mortality. So it's important that at our clinic we screen everybody for vitamin D deficiency, because that can play a role in lung immunity. And also we screen for something whose technical name is sarcopenia, but it basically means that you've lost your muscle mass and your function. So your muscles are much weakened. If you have this, it's important that you get referred for specialist dietitian care, and that's either in-house in the hospital or via our community colleagues. Next slide, please. Now, when I was looking into this topic, I was looking to see were there models of care for interstitial lung disease, and I came across several, and I found them all to be very similar in their approach. They all share a similar theme in that they are patient-centred, they're collaborative, they're inclusive, they want to work in partnership with the patient, they want to provide comprehensive disease management that's aimed to optimise quality of life, and they also want to provide symptom or supportive care. So if we move on to the next slide. Okay, so a Dutch group, I'm not going to attempt to say this name because I know I'll fail miserably, but they proposed individual care plans should be formulated using a model treatment framework to meet complex needs of fibros and interstitial lung disease patients, and advocates self-management support. So next slide, please. So self-management support is defined as a systematic provision of education and supportive interventions by healthcare staff to increase patients' skills and confidence in managing their health problems, including regular assessment of progress and problems and goal setting. And so typically this would include you adopting a healthy lifestyle, preventing complications such as exacerbations, so avoiding the potential of getting chest infections, so avoiding loved ones if they've got an infection, and also making sure you avail of all the preventative vaccinations. It means adherence to your treatment plan and your medication. Home monitoring of symptoms can help, and also known objective illness indicators. So what are the signs that you're going downhill? What are the red flag signs that indicate that you weren't being seen by your healthcare professional sooner? And being able to make those decisions appropriately so that you know when to see that health professional and not to delay until your next clinic visit maybe. So it's important that you're communicating and interacting appropriately and productively with your healthcare worker and in the broader health system. Next slide, please. And this is the final slide. So the key messages I'd like to leave you with are that interstitial lung disease patients' needs are unique. They're often very complex and they require comprehensive care plans tailored to their individual requirements. And information and support are paramount at every stage in the disease trajectory. So high quality disease related education of patients and health professionals, including what to expect in the future if the disease worsens. And I believe that specialist ILD centres have the prerequisite knowledge and skills to manage the varied ILDs by a comprehensive MDT care approach to patient care. And in the future, it is hoped, and it's currently being devised, a dedicated interstitial lung disease national programme will come into existence. And that is essential to ring fence the necessary resources so that we can build excellence into ongoing care provision, and also devise standardised treatments and referral pathways. And one would hope that this would be in an electronic manner to speed the process along. And so finally, we need continuous collaboration and trust among patients, families and their healthcare team. And those are the foundation of comprehensive care in ILD. Thank you very much for your attention.
Thank you for that. I'll just end the slideshow. Yep. There's a couple of questions that's come in, Lindsay. I know you're on a mobile phone and you're working in a hospital at the moment, so we will send them across to you. If there's any extra questions, we'll send them across and hopefully you can answer it that way.
Okay, thanks very much. Thank you.
Thank you. I'll pass back over to Eddie.
Thank you, Lindsay. Great presentation, very detailed. Thank you so much.
You're more than welcome. Thank you, Eddie.
Our next speaker is Leah Harrington. And Leah is the Wellbeing Coordinator for the Health Service Executives Living Well programme. Leah will talk about the Living Well programme, and we look forward to hearing more about this very important initiative.
Thank you very much, Eddie. Thank you very much, and thanks for having me. I'm delighted to be here this afternoon. So my name is Leah Harrington, so I'm the Living Well Coordinator within CH09. So I just wanted to tell you a little bit about our Living Well programme. So what is it? It is a scripted programme. It is licensed through the SMRC in California. There's a group of 10 to 12 participants. We have 2 trained facilitators, one of which will be living with a long-term health condition. And we have one session that's 1.5 hours, and we call that session 0, just to make sure everyone can get online okay. And we give a brief overview of the programme. And then for the following 6 weeks, then it's on for 2.5 hours. So what does it do? So it supports the development by enhancing self-advocacy, which is a person's personal belief in their ability to complete or achieve a goal. And that's where action planning will come in. I'll talk more about that. Improving health behaviours, so getting proper exercise, physical activity, healthy eating, nutritious foods, practicing good sleep hygiene, taking medications as prescribed, and then working with your healthcare providers. Improving social engagement, so being engaged with others in your community, the ability to develop and maintain friendships, communication, creating boundaries in friendships and relationships, and having a supportive network of family and friends. Then lastly, reducing the feeling of low mood, depression and anxiety. So prioritize sleep as is interconnected with your mental health, staying active and to go outside. Daily exercise has been shown to help alleviate symptoms of anxiety and depression, and focus on healthy eating and practice relaxation and then understanding emotions. So this is what we would call our symptom cycle. So I'm sure a lot of people here today might be familiar with some of this. I too would live with chronic health conditions. So it can often affect poor sleep. You'd have physical limitations, there's pain, stress, difficult emotions, low mood and depression, shortness of breath, fatigue, and this goes nicely around in a circle, but as we all know, with a symptom cycle, it can take any direction. So here we have our self-management toolbox. So your physical activity, medications, decision-making, action planning, breathing techniques, sleep, problem solving, using your mind, understanding emotions, communication, healthy eating, and working then with your providers. So what this box does then, say if we're looking at physical activity, we'd use that to break the symptom cycle. So physical activity can relieve pain, stress, can help with your difficult emotions, lift your low mood and depression, shortness of breath, fatigue, and poor sleep. And again, sort of communication is really prevalent as well. If you're trying to talk to, say, some of the healthcare team or your family about how you're feeling or that, if you have sort of really good communication, that can really help with your stress, can help with your difficult emotions, then lift your low mood and depression. So decision making and action planning and problem solving are our main tools in our toolbox. So we're just going to have a look at what the skills we're going to learn during the course. So as I was saying, making decisions, action planning and problem solving are our core skills. The other techniques you learn during the program is dealing with difficult emotions, pain and fatigue management, exercise and physical activity, relaxation techniques, better breathing, healthy eating and weight management, communication skills, dealing with low mood and depression, and making informed treatment decisions. And obviously, with any of these programs, you would follow the medical advice that you've been given by your doctor, GP, or specialist when it comes to any of the techniques that we do on the program. So self-management skills. So what you learn as well would be like dealing with pain and fatigue, coping with difficult emotions and feelings of depression, looking at exercise. And we don't talk about going out to do Mr. Motivator or anything like that. Again, exercise is from where you are in the here and now. And again, following like information from your GP, doctor, or your physio before doing anything like this. Healthy eating, managing medications, problem solving, decision making, goal setting, communications, and then local supports. So in the first week, we'd give you an introduction into the workshop. We'd have then group introductions. We'd outline the general principles of self-management and introduce you to the toolbox, which you just saw in my previous slide. We discussed the mind and body connection and distraction, introduction to brainstorming, getting a good night's sleep, and then our introduction to action plans. And the introduction to action plans is something that you'll be doing every week for those 6 weeks. So action planning exercise is something that you want to do, and that's really, really important when we're setting out an action plan. It's not what you think your family wants you to do or a friend wants you to do or someone else. It's really what you want to do. So it has to be achievable. So if we are having a program starting on a Saturday, when you report back, you would have achieved it in that week. It's going to be a specific action, and then you answer these questions: the what, how much, when, how often. Then you would have a confidence level of 7 and more, and then leaders would always start with their action plans and how to model it's done. So for instance, someone's action plan might be that they want to go out for a walk. The what is the walking, the how much could be 10 minutes, when they pick the evenings or days, so that could be Monday, Tuesday and Wednesday, and then how often if we could 3 times that week, and the competence level would be 7 or more. So if someone had a competence level of a 5, we'd sort of work through how we could break that down and maybe reduce the day that they want to go out for a walk. You can do meditation, you can do flower arranging, you can go out for coffee with your friends. So the action plan is something that you really want to do, and it's not written in stone. So if you're having sort of a bad week or anything like that, you know that you can change it. So in week 2, we'd have the feedback from your action plan, and we'd also introduce problem solving. We look at dealing with difficult emotions, an introduction to physical activity and exercise, preventing falls and improving balance, and then making an action plan. In week 3, we have the feedback on action plans again. We look at making decisions, pain and fatigue management, endurance exercise, relaxation body scan, and then we'd make an action plan for the week ahead. In week 4, again, we'd have the feedback on the action plan, better breathing, introduction to healthy eating, so that'd be the weight, BMI, controlling blood sugars, cholesterol, and we'd also look at the plate method along then with the HSC's recommendations and of the food pyramid, reading food labels, communication skills, and making an action plan. Week 5 will be the feedback again on the action plans from the week before. Then we look at making healthy food choices, medication uses, making informed treatment and decisions, dealing with depression, positive thinking, and then action planning. And on our last week, we reflect on your action plan. We look at working with your healthcare professionals. So that's really getting the best out of your GP appointments, medical appointments, and everything like that. We look at weight management, and then looking back and planning for the future. So normally when we're looking back and planning for the future, it would be an action plan for the next 3 to 6 months, but that is broken down into very small doable steps. And that's one of the most important things with an action plan, is to break it down into the smaller, more doable steps. And this is just an overview of what you'd be covering. So if you're looking at, say, week 1, we have an overview of self-management and the chronic health conditions, fatigue, getting a good night's sleep, using your mind to manage your symptoms, and then making an action plan. And you can see the action plan is there for every week going across. So if you couldn't make, say, like a session 2 or 3, you know exactly what is coming up in that session. And at the back, it's called homework. It's not homework. We don't check it or anything like that. This is just additional reading if you wanted to read up on different subjects that we'd cover. Because we only have the 6 sessions, there's a lot that we cannot cover. So this will be just additional reading for you. So what do you need for the program? So pen and paper is handy, as often suggestions during a session that you might feel useful. So what will be posted out after session 2 is those inserts that I showed you. You also get a great free book, and it's called Living Well. There, you might be able to see it properly, but I can say it. So it's Living Well, a healthy life with chronic health conditions, which is really good. And then you get the course view overview, and my colleague Louise sends out all those inserts after session 0. So who can attend? So anyone with a long-term health condition, anyone caring for someone with a long-term health condition. You must be over 18 and it's not suitable for anyone with significant intellectual impairment or advanced dementia. And also to say that the program is totally free as well. So building a stepping stone in confidence. So you have the little figure here, I won't do it. Sort of, I can't do it, I want to do it, but how do I do it? So sometimes when we are living with chronic health conditions or chronic pain or anything like that, we sort of want to know, how can we do the things that we used to do? But sometimes we have to change how, and I know sometimes for me, I do things 10 times better now than I did before I got my health condition. So then you look at, okay, I'll try to do it, I can do it, I will do it, and then you have success. And that's sort of something that sort of reflects our program very much, because it's done in stepping stones and it's done in small doable steps as well. So this is just some feedback we've gotten from our past participants. I value my health so much more since completing this program. It's the biggest gift I ever gave myself. Action plans have helped me control not getting overwhelmed. I never knew this was possible. I'm now talking to my family about my condition, to my family and friends, because this program taught me how to do so. I'm not isolating myself as much thanks to this course. Leaders, facilitators giving their own personal experiences really helped that they just got it, and it added value to the programme. The programme is extremely well planned and thought through and covered a lot of useful and practical information and tips. It was great hearing the other participants share their experiences and useful tips. The way the group was managed was very professional and empathetical at all times. Everyone felt safe in sharing. I went for my first walk in nearly 2 years thanks to your programme, as I was terrified to go out with living with long COVID. I was bullied my entire life except for now, so thank you. I'd been reluctant about agreeing to participate when my district nurse contacted me initially, as I didn't think it would be of any use to me. On the contrary, it's been a wonderful motivator in kickstarting my exercise regime, which I've been procrastinating about for years. It showed me that exercise has a huge knock-on effect on my whole well-being, diet, weight loss, physical, and especially mental health. The content and the information provided is very helpful and insightful, and it made me feel such a difference in my everyday life, coping with chronic conditions. All the handouts and the book are fantastic resources going forward. So just to mention some of the other programs we run. So we run this program I just talked about, Living Well with Chronic Health Conditions. And we also run this also for different organisations as well, just specifically for their own members, because it's nice to meet other people living with the same condition as yourself. We also run Living Well with Chronic Pain Self-Management Programme, and Living Well, Building Better Caregivers. I know Sean mentioned that in his speech there, so that might be something relevant to any carers on here. Living Well, Cancer Thriving and Surviving. So this program is for anyone who has been given a cancer diagnosis, who is a year post-treatment, or for family members or friends supporting someone going through a cancer diagnosis. Workplace Living Well with Chronic Health Conditions, and we also do Living Well with Chronic Health Conditions for people living with long COVID. And just to say that because we're the only sort of CHO area that are running the chronic pain, the carers, and the cancer program, it is open to everyone outside of Dublin, which is brilliant. So just to say, the next date of our program is starting on the 16th of January, and that runs to the 27th of February. So we have a morning program, and we also have an evening program as well. And I'll send on the details of that to Gemma as well. And just to say, when I is replaced with we, even illness becomes wellness. And that's something that people experience on the program. As living with a chronic health condition, we can often feel very isolated. So when we come onto this program, that we just ourselves, but when we leave it, we become sort of a we, and like it's, you find your own tribe. And as I always say, if Malcolm X says it, it has to be true. So just to say thank you very much for inviting me here today. And I really enjoyed all the previous presentations. So thank you.
Thank you for that. We're conscious of time, so I shall, if there's any other questions, I'll pass them across to you. But on to Eddie for our final speaker.
Thanks, Justin. Thank you, Leah, for a really, really interesting talk there. Thank you. And my apologies to Patricia. I forgot to thank her at the resumption of part 2. So Patricia, I apologize, and thank you again for a very, very interesting talk. Our final speaker today is Frank O'Connor from Dublin, and we are delighted to have Frank share his story with us today. So Frank, I'll hand it over to you now.
Well, first of all, good afternoon, and thanks Eddie for your introduction. And a big thank you to ILFA for this opportunity to tell my story. My story can really be summed up in one word. That's just gratitude. My name is Frank O'Connor. I'm married to Bridget. I have 4 sons, just to get in perspective: Peter, Brian, David, and Alan. I'd like to pay tribute to my brother Jade, who just passed away 6 weeks ago at the age of 73 with pulmonary fibrosis in Vincent's hospital. May you rest in peace. My story really began last year, 17th of February, in the Beacon Hospital, when the respiratory consultant confirmed that I had idiopathic pulmonary fibrosis, IPF. I didn't know what it meant at the time, but I obviously know a lot more about IPF now. He said it's an incurable disease. There is no known cause. There is medication, he said, that could slow the disease down, but it's not a cure. He said you're at the right age of 65, that you might be considered for a lung transplant if found suitable. And then he told me, which kind of shocked me at the time, but I'm delighted he told me at the time. He said, go home and get your affairs in order. And we thought within the next 3 days, I had an appointment with my solicitor to get my will sorted out, just in case, because my condition was progressively deteriorating rapidly on a weekly basis. I went home and I started Googling IPF and what it meant. And I came across ILFA, which is, as you all know, with the Irish Lung Foundation Association. And as it happened, they had a conference like today, a Patient Information Day, in 3 weeks' time, which was last March 2022. I logged on to the conference, and it is like a lot of people logging on this morning for the first time, and they're going to feel stressed and anxious that maybe they had a diagnosis recently. For me, what really helped me a lot was the acceptance of my disease. I now realized I had an incurable disease. And I wondered why my attitude was changing. And I normally fluctuate with a happiness index of between 3 and 7 out of 10. And I wondered why did my happiness index increase up to 8, 9, even 9.5 out of 10 after my diagnosis. And I found out it's quite simple. We live in a state of either past, present, or future. And I realized after my diagnosis, my future had disappeared completely. So now I knew I couldn't live in the future. I had to live in the present. That's what most people try to achieve, is to live in the present, and it isn't easy to live there. But once you do find out you have to live there, your happiness index, I promise you, will go way, way up. And I'm up to, with most of the days, I'm up to 8, 9, and even 9.5 out of 10. I came across the formula actually as it did happen. The suffering equal to pain multiplied by resistance. The more we resist our pain, the more we're going to increase our suffering. And I found out by substituting our pain with gratitude, we can reduce and maybe eliminate our suffering. The gratitude releases 2 hormones, serotonin and dopamine, into the brain, which is also found in alcohol and some illicit street drugs. So it shows that the power of gratitude can really increase your happiness index. Despite living in the present moment, after my diagnosis, my disease deteriorated, and eventually I was on 15 liters of oxygen per minute during exercise. Thankfully, after a week's-long test in the Mater Hospital, I was listed on the life transplant register. And within 3 days of being on the register at 10:27 on a Wednesday morning, you know at the exact time, I was about to log on to the ILFA yoga class with Michael Darren McCauley. I got a phone call and I recognized the voice. It was Mary, the transplant coordinator in the Mater Hospital. He said, "Where are you, Frank?" I said, "I'm at home." "Have you got your bags packed?" I said, "I do." He said, "We'll have an ambulance outside your door within 20 minutes. And then she said the words that kind of shocked me, and it meant so much to our family for the rest, probably for the rest of our lives. We have located a suitable organ donor. My son David was with me at the time. He rang my wife, and obviously they were going to make their way into the hospital, because I was in the hospital within about 10 minutes after the phone call. That evening at 9:30 p.m., I was wheeled down to the theatre for the 8-hour transplant operation. And at 6 o'clock the following morning, the transplant was completed successfully. But things were about to change slightly. At 6:30 a.m. the same morning, my wife got a phone call to say that your husband is very ill and you better call the rest of your family. There was some reckless driving from Tipperary and Kilkenny and Dublin with my family to get to the hospital in time. I spent a long time in ICU, over 80 days, because I got 3 major infections. But thankfully all went well. I was discharged on the 14th of December last year, after spending 132 days in the hospital. I survived the ordeal due to 2 major reasons. I had a world-class medical team behind me between the Mater Hospital, and finding gratitude in everything, it really, really helped me. I keep a gratitude journal every day, and every evening I write into the journal 3 or 4 things I'm grateful for on a daily basis. On June the 24th, this was my first time ever in the Mater Hospital, but last year I had an appointment with Dr. Michelle Murray, which is the lead clinical consultant in the Mater Hospital over the heart and lung transplant section. And this is what I wrote into the journal, and I'm going to read it out very short. My appointment to see Dr. Michelle Murray, I was extremely impressed with Dr. Murray's personality and her empathy to her patients and her overall love for her profession. I was unexpected to meet another girl that day, which was a senior respiratory physiotherapist. I didn't know her at the time, but she's now my superhero. She is Olive McCafferty. I know she's on a panel this morning, and this is what I wrote about Olive. I was equally impressed and full of gratitude for the physio who brought me on the 6-minute walk test. He was also very empathic and demonstrated great love for her job. I could feel the love flow from her. If we could give a Michelin star for healthcare, I definitely have to give it to the Mater Hospital. I'd like to say a public thank you to the organ lung donor, to the family, for the life-saving gift. It is surreal to think after all the possibilities, I was the one chosen to be the recipient of this life-saving gift. Your gift has an incredible act of generosity. Now I get to spend Christmas for the second year post-transplant with my wife and family. My sincere thank you, and thank you for my family as well. Finally, my disease isn't just about me, Frank O'Connor. It affects my wife, it affects my family, and it affects my grandchildren. But it is different for them. The more I become aware of the issues, the more grateful I am for my family's love each day. That's about it in my story in about 7 or 8, 9 minutes. Thank you very much.
Thank you, Frank. I'm lost for words. I'll hand over to Eddie on that. I think everyone on this side is applauding, and we're getting lovely messages as well on the Q&A box as well there, Frank.
Okay, that's good.
Yeah, thank you, Frank. A wonderful story and a wonderful ending. And sure, you'll be back in 10 years' time to give us another update.
Okay, no problem, really.
Thank you so much. That's all our speakers, folks. So if I can just give my sincere thanks to all of the speakers today, and for their time, their expertise and kindness. It was a really, really good series of talks. I'm very grateful to Gemma and to Anne for their very hard work, all behind the scenes. Thanks again to both of you. We're enormously grateful to Justin Dawson for his help in managing the technology and to deliver this event online. So thanks again, Justin. I would also like to thank Boehringer Ingelheim for supporting the event. This year, ILFA is celebrating our 21st anniversary, and our success to date is due to hardworking board members who run the charity, and thanks to all our really, really loyal and very generous fundraisers. ILFA's work and events like this would not be possible without their hard efforts. ILFA depends on fundraising and donations, and all support is greatly appreciated. If I may say that if you are a family member or a member of a club or a society or a company, please consider ILFA as a potential charity partner. We would welcome such an opportunity with open arms. Please consider buying some ILFA Christmas cards this year to raise funds and to
Oh, sorry. I think we might have lost Eddie at the very, very last minute there. Gemma, do you want to just jump in there?
Sure. Eddie was going to ask if people can support our Christmas cards for funding, but even more importantly for awareness. He's back.
Yeah, sorry, Eddie, we just lost you at the last minute there talking about the Christmas cards.
Yeah, but if you could please fill in the ILFA survey on what matters in the patient registry. you will have received an email with regard to this. So please find the link and fill it in. We hope you enjoyed this Patient Information Day, and you will join us at our next one, which will be in 2024. Wishing you a lovely weekend. Stay safe. And if I may take the opportunity of saying, I wish you all a happy Christmas and a very, very healthy and prosperous New Year. Slán.